Hello. I'm imagining I'm speaking to a physician, nurse, respiratory therapist, or other healthcare professional. Thank you for taking a few minutes to watch this brief video on total laryngectomy. Your patient will appreciate your doing so, and so do I. I'm Robert Bastian, a laryngologist with Laryngopedia and Bastian Voice Institute. Your patient has undergone a total laryngectomy, and several of my patients have told me that in emergency rooms or hospitals, they somewhat understandably encounter healthcare workers who aren't quite sure what that means. So one patient described a well-meaning respiratory therapist trying to deliver a nebulized treatment for an asthma attack by face mask without realizing that air can no longer reach the lungs that way. Another mentioned that a nurse tried to administer oxygen also via a face mask. And yet a third patient was initially intubated during a code through the mouth. No harm came to him, but because they quickly realized the error. But for those not deeply familiar with the practical realities of total laryngectomy, let's briefly review what you need to know to care for these patients safely and effectively. Now, background: in a typical person, the throat serves two primary functions. We're leaving voice out of it. We're just talking about breathing and swallowing. So for breathing, air travels through the nose or mouth into the throat, then into the larynx, trachea, and lungs. For swallowing, food and liquid go through the mouth and then into the throat and into the esophagus. So the throat is used for both breathing and swallowing. And fortunately, the throat is an incredibly skilled sort of switchboard that allows us to alternate seamlessly between these two functions. Now, in a tracheotomy patient, and most healthcare professionals have seen lots of tracheotomy patients, in that group, the patient just has a second airway opening, a side hole in the trachea, but they still retain the normal route through the nose and mouth. So air can go either way as long as there's no obstruction above the larynx, and aspiration remains a concern if the patient swallows incorrectly, even if they are NPO, because of course saliva can soil the airway and create pneumonia. But in a total laryngectomy, it's completely different. Obviously, in removing the larynx, the trachea is amputated. So here's the larynx, and the larynx is removed, and the trachea is amputated just below the larynx, and then it is angled forward and sutured to the skin of the lower neck. And that creates a permanent stoma, not a side hole. So they actually technically have a tracheostomy, not a tracheotomy. So it's an end point opening, not a side hole opening. Now, air reaches the lungs in these patients only through the stoma. The nose and mouth no longer connect to the lungs. The throat serves only for swallowing, not for breathing. Now, most have had voice restored by making a tiny hole in the back wall of the trachea and into the esophagus behind the trachea. So that little hole wants to heal shut, just like a pierced earring does or a nose ring does, and so you have to leave something to keep that opening, to keep the opening. And here in the tracheoesophageal puncture, that has to be kept open with a tracheoesophageal prosthesis, a tiny silastic device that has a one-way valve. When the stoma is occluded with the thumb or with a little button that we attach, then the patient breathes out and some air is forced through the one-way valve into the esophagus to produce tracheoesophageal voice. Kind of like this. It's a rough voice. It's a rough voice, but it's functional. That same valve closes when the person swallows so that no food can come forward. So air opens the valve in the posterior direction to let air into the esophagus, but when we swallow food or saliva, the valve closes in the forward direction so that nothing can come anteriorly into the trachea. But back to the big picture, with separation of airway and foodway, and assuming that the TEP device is functioning and the valve is working, aspiration is no longer a routine concern. You'd have to pour liquid into the stoma to create aspiration. or if there is a leak through the tracheoesophageal puncture or the voice device, then you could have aspiration. Normal airway for me, for example, is one front door. That's my only way of breathing, through the front door. Tracheotomy, I still have a front door, but I also have a back door. Total laryngectomy, only a back door through the neck. Total laryngectomy patients are neck breathers exclusively. Well, what are the practical implications in healthcare settings? Number one, no face masks or respiratory therapy over the nose and mouth. They would do nothing. Treatments of that sort must always be via the stoma, using a trach collar, or you can use a very small pediatric face mask, and it'll fit, pardon me, right over the stoma. Intubation cannot be done through the mouth. Trying to intubate through the mouth would send air into the esophagus and stomach, not the lungs. Any ventilation must go through the stoma, again by that little pediatric air mask, face mask, holding it over the stoma, or by inserting an endotracheal tube into the stoma. It's important, however, to only insert the tube a few centimeters. Most of the tube will remain to the outside. It looks different than when we intubate through the mouth. Now, intubation is usually very straightforward. It's easy. The TEP device that I mentioned, it does not dislodge easily, but still be a little cautious to avoid catching and dislodging the TEP prosthesis. When you insert the endotracheal tube, sort of angle on the forward side, back towards yourself. Don't push posteriorly towards the TEP, because you could catch the little flange and dislodge it. Now, if the TEP is dislodged, look around carefully, see if you can find it in the bedclothes or on the floor. And if you can't find it, then you do have to get a little ENT scope. It's not an emergency. Just take your time, but at some time in the next few hours, somebody has to look and make sure that the device isn't in the trachea or in a bronchus. Now, in the meantime, with that TEP device out, there will be unrestrained flow of saliva. Each time the person swallows, they'll kind of squish some saliva forward. Easy to manage that. You just take a number 14 red rubber catheter, tie a knot in the proximal end, insert it through the little hole and into the esophagus, and then just either tape it in place or put a trach tie around the neck. And so that will keep saliva from coming forward, and it'll also keep the hole from healing shut. So in summary, your patient with a total laryngectomy cannot breathe through the nose and the mouth. All respiratory care, oxygen nebulizer, suctioning, and intubation must be done via the stoma. Aspiration is not a concern unless the TEP leaks, and standard airway protocols do not apply. All airway interventions are via the stoma. And finally, a dislodged TEP, if you look and there's no TEP device, then try to look around and see if it's on the floor in the bedclothes. And if you can't find it, then get someone to just come routinely and look in the trachea and the bronchi. And in the meantime, insert a red rubber catheter so that saliva doesn't keep flowing, and to keep the TEP from healing shut. No emergency, no stress. It's just very straightforward. Well, thank you once again for taking the time to learn what your laryngectomy patient needs. Your understanding makes a real difference in their safety and quality of care. And again, I'm Dr. Robert Bastian, and I thank you for watching.